I'm Steve Daveluy, professor at Wayne State University in beautiful Detroit, Michigan, board certified dermatologist, and board member of the HS Foundation. Always happy to talk to you about hidradenitis suppurativa, and today I'm going to focus specifically on laser hair removal. We're going to go over the evidence for laser hair removal, the actual procedure, kind of nuts and bolts, and then also cover the coding and billing options that are out there. So hopefully by the end of the talk, you'll be comfortable bringing this treatment to your patients with HS. So this is a brief recap of the evidence for laser hair removal. Right now, we have the most evidence for the ND-YAG laser, followed by alexandrite, IPL, and diode. I will tell you that all have evidence, so we do kind of believe that any energy-based or light-based hair removal seems to be beneficial for HS. So if you have any of these devices, it is an option that you can offer your patients. The procedure is pretty simple, and we'll go over it again, but you basically are going to treat the entire area just like normal laser hair removal. So for most lasers, that means overlapping about 30% from side to side and top to bottom to cover the maximum amount of area. And then you just double pulse any active lesions. So as you're going through treating the area, if there's a lesion, you can pulse it twice, or you can treat the whole area and come back and pulse the lesions. That's sort of the way we've always done it, because ultrasound studies have let us know that almost all HS lesions, if not all, have a hair inside of them. So we're trying to sort of get to that hair and treat it. Having said that, we've never done it without double pulsing the lesions, so maybe it doesn't make a difference, but it's what we've always done, and it's where the evidence supports us doing it for now. It typically requires 3 to 4 to even 6 or 8 treatments like normal laser hair removal does. And you can see overall, we see about a 60 to 70% reduction. It's more effective in areas that have more terminal hairs. So the inguinal and axillary skin responds better than the inframammary, where there doesn't tend to be as many terminal hairs for the laser to target. It also works better in earlier stage disease. So most of the evidence is best for early stage 1 and 2. Once you start to get a lot of scarring and tunnels, there might not even be hairs left, or maybe they're all kind of trapped under the surface and the scars are in the way of the laser. But laser hair removal is really most effective in earlier stage disease. In the original studies, laser hair removal was studied just as monotherapy, but in practice and in some more recent studies, we've combined it with other anti-inflammatory things. So I will typically start patients on an antibiotic course like clindamycin or a tetracycline, spironolactone, maybe even a biologic, and then we'll get the approval and add laser hair removal onto that. So it's not very frequent that I'm using it as monotherapy. It's not very frequent I'm using anything as monotherapy in HS, to be honest. The box at the top lets you know that according to the only available but most recent North American treatment guidelines, ND-YAG laser hair removal has a level of evidence of B and strength of 2. So we are working to update the North American treatment guidelines because there's more evidence that has come out for some of the lasers. So that'll be in the works and hopefully give us even more strength when going to insurance companies and asking for approval. The ND-YAG has had 4 randomized controlled trials with 99 patients. As I mentioned, they had 2 to 4 monthly treatments. Most of the laser studies have been split side design. So you treat one axilla and leave the other untreated as the control. The one challenge with that is sometimes reducing the overall inflammatory burden even results in some improvement on the untreated side, but it's a good way to do studies with the split design when you have bilateral involvement. And as you can see, as I mentioned, there's a 30 to 72% improvement across all the trials. And then this little box here just highlights one of the most recent trials where they did 4 treatments at 6-week intervals, again, split side. And you can see there was a significant decrease in the lesions 1 month post follow-up, and they maintained a decrease in lesions, but it lost its significance at the 3-month follow-up. I do typically tend to see more lasting results with laser. If patients respond, they tend to do really well, and then I may see them a couple years down the road when they need a touch-up and need a couple more treatments. Again, everything with HS is variable, so it might work great for one patient, not so great for another. Like I said, patient selection is key. So you really want to pick early stage 1 and 2 disease, not the patients who have HS taking over a whole area with scars and tunnels. And it seems to possibly work a little better for the follicular type, where they have sort of folliculitis in the areas of the HS, or folliculitis as sort of a precursor to the HS lesions. INDIAG has also been studied for prevention in very early disease. So this study had 27 patients with early stage 1. Again, that follicular subtype where they have sort of that folliculitis appearance. They used the settings demonstrated here. And treatments were every 4 to 6 weeks. And their goal, their endpoint was cessation of hair growth. So the mean number of treatments in this study was about 9.8. They didn't use a standardized outcome measure to measure the improvement, but you can see they used an NRS scale and saw a reduction in the severity and the number of flares per month. 2 out of 3 patients would recommend it to others, and the majority did reach that endpoint of hair reduction. So this is a good thing to use. I use it a lot in patients. I'm seeing more patients now who are coming in saying, you know, my mom has HS, hers has gotten really bad. I'm starting to get it. How can we prevent this? And I say there's evidence for laser hair removal. If that's a good option for you based on skin type, hair color, and other factors that factor in, you know, overall insurance approval, all the things we have to deal with. INDIAG has also been studied in adjunct to other lasers. So for 4 patients who underwent CO2 deroofing and then had recurrence, the authors used INDIAG to sort of pre-treat the area, and then about 2 weeks later did CO2 deroofing and noted no recurrence after 3 years. The concept there is sort of like pilonidal cysts. You remove the hairs and treat the area and do the surgery, and then the risk of recurrence goes down because the hairs aren't there to serve as a nidus for new lesions. So as I mentioned, we've known this for a while in pilonidal cyst and pilonidal sinus, that if you add laser hair removal to the surgery, the recurrence rates drop off a lot, which is really great for patients. It was also combined with fractional CO2. So in this case, some patients got INDIAG laser hair removal. Some were pre-treated with fractional CO2. And the concept was the CO2 is going to make little micro holes that will make it easier for the INDIAG to then penetrate down to the roots of the hair follicles and get where it needs to be. And sure enough, you can see the improvements were better for the combined therapy than for just the INDIAG alone. This does make things a little more complicated in terms of cost and insurance coverage, but it could be an option for patients if they can afford it or you can get it covered. As I mentioned, for the North American treatment guidelines, IPL, alexandrite, and diode all had level of evidence of C because they didn't have a strong body of evidence, but still some. So IPL had a prospective study with 18 patients where they used 420 nanometers, again, split side design, and you can see 50%, around 50% improvement at 3 months, and it lasted a while, though there was a little bit of a tapering off of the improvement. Alexandrite and diode at the time of the recommendations, the treatment guidelines only had case reports to support them, but since they have mounted more evidence, so in the new guidelines, they'll have stronger evidence. Alexandrite was studied in a randomized controlled trial with 20 females, early stage 1 to 2. One group got zinc and oral zinc and chlorhexidine wash, and that was the control group. The other group got zinc, chlorhexidine wash, plus alexandrite hair removal. And you can see the improvement of the high score, which is a 50% improvement in abscesses and nodules with no increase in draining tunnels or no increase in abscesses, was 70% for the laser group, 20% for the control. Pain and quality of life were also significantly improved in the treatment group. And you can see they had a longer disease-free interval after the laser hair removal of about 26 weeks. So this was one randomized controlled trial. And then here are the results from the one that we did right here in Detroit. So we enrolled 15 patients, 24 sites, 80% were early stage 2, the remainder early stage 1. Again, that split side design. We did 4 treatments about every 4 weeks, and they were allowed to use topicals of Clinda solution and benzoyl peroxide wash, but they had to use it on both sides. So it served as sort of a control. And you can see the high score, that 50% improvement at week 20, so 4 weeks after the last treatment, was 75% for the laser group and about 33% for the control. And you can see, again, we had that differential. We did see a higher response in the inframammary region than we usually expect, but that may be because one of the patients was male and actually did have more terminal hairs in the area. And it was a small number. We only had 3 sites in that group. The diode also has more evidence to support its use. A retrospective study of 16 patients with 2 to 4 sessions showed the modified HS score to have significant improvements, as well as the physician global assessment. 80% of the patients reached a high score of 50, and the DLQI also showed significant improvements. So more evidence for more of our types of lasers, which is great because that gives us more options no matter what kind of laser you have. Here's the slide with the settings. So if you want, you can pause the video or take a screenshot and write these down. But if you don't want to write them down, I can tell you these are basically the normal laser settings. So you check your patient's skin type, your spot size, and you can adjust your settings and you treat it just exactly the same as normal laser hair removal or cosmetic laser hair removal. The procedure is basically exactly the same, except you double pulse those lesions. So you, based on the patient's skin type and your laser, you do your initial settings. Each treatment, you increase the fluence a little bit as long as the patient isn't having any side effects, and you just double pulse those lesions. I do counsel patients that sometimes they may have a mild flare-up after the first or second treatment because we're kind of disrupting things under the surface a little bit. So they might expect more drainage, maybe even a little bit of a flare. But often, as I mentioned, they're on medical therapy at the same time, be that an antibiotics, spironolactone, metformin, a biologic, and that can help to kind of blunt that flare-up that we can see with that first treatment. But I still warn patients about it. I also counsel patients about the normal side effects of laser hair removal, mostly dyschromia. Ironically, when you start talking to an HS patient about dyschromia, they often look at you a little puzzled and go, have you seen what the HS is doing? I'm not worried about some discoloration. Just get rid of my pain and pus and swelling and drainage. But I still counsel them that they might have some discoloration. It's usually temporary and we try to avoid it. The ND-YAG laser has the lowest risk for darker skin types because of its longer wavelength and deeper penetration. But as I said, our trial, we included patients of all skin types with our Alexandrite laser and found it was safe and effective. And patients weren't bothered even if they did get a little bit of hyperpigmentation. It was temporary and they wanted to continue because it was helping their HS. Now, in terms of coding and billing, there's a couple options. One is you can use the 17999 code, which is unlisted skin procedure. The hard part with the unlisted skin procedure, it's the code you use when there's no code for what you're doing. And there's right now no code for laser hair removal for medical purposes. So what you have to do is you ask the insurance if they'll cover that for HS. In my situation and people I've talked to, they often will tell you, yes, they'll cover it, but they won't tell you how much they're going to reimburse. You have to actually do the procedure and submit a claim and then see what you're going to be reimbursed. So my process is I get that approved. I do the first treatment, submit the claim. I have my billing department let me know what they actually reimburse. And then you may have to adjust the number of treatments or the number of areas you treat in each session based on what they reimburse, just to make sure you can keep the lights on. So I'll kind of tell patients like, oh, your insurance does cover it, but they only reimburse for us to do one area at a time. So we're going to do your armpits for 4 to 6 treatments, then the groin for 4 to 6, then whatever other areas you have. And patients are usually happy because just knowing that the insurance is covering it makes them feel better. They don't have an out-of-pocket expense for it, and it has some benefit. I will give them, just like normal laser hair removal, I'll prescribe a numbing cream to use in the more sensitive areas that can be a little more painful. Usually axilla is not a problem, but the groin can be an issue. The other option, if you don't want to use the 17999 code, is you can use your destruction codes, because the destruction benign code is destruction by any method, and it specifically includes lasers. So you can use the 17110 or the 17111, depending how many active lesions they have or lesions total. And so you can kind of figure out, I still do recommend you get a prior authorization with the insurance to be sure that they will cover destruction benign with the diagnosis of hidradenitis suppurativa. I found in my practice, usually the 17999 reimburses a little bit higher, but it varies insurance to insurance, and it can be unpredictable. So wrapping things up, if you've got a laser, you've got a treatment option for your patients with HS. If you don't, you might be able to reach out to people in the area who have lasers and kind of show them this video, help coach them through it, and then you have a way to refer patients to get laser hair removal. It's most effective in early disease, early stage 1 and 2, less effective once scarring and tunneling starts to show up. Doesn't mean you can't try it, or if the patient has early stage 3 in one area, treat the other areas. More effective when there are more terminal hairs, so axilla and groin more than the inframammary. It does have the potential for prevention in early disease, which is really great. It sort of removes that nidus of disease, which is the hair follicle. Evidence is there for all light-based hair removal devices, including the diode, alexandrite, IndiYag, and intense pulse light. The procedure is the exact same as regular laser hair removal, including choosing your settings, going about the procedure with your overlap, the spacing in between treatments, all the same as regular laser hair removal. The only difference is you're going to double pulse any active lesions. With that, I hope you feel equipped and ready to bring this effective treatment to your patients with HS. And as always, I want to thank you for treating patients with HS because there's such a need. We need experts out there so every HS patient has access to a dermatologist who's an expert in treating HS. Thanks so much.